Hi, Mike Gibson, Jerry Granato coming to you live from SCAI 2016. In the old days, we used to do trials where we had these little centers and principal investigators. Well, we still do that.
Right.
But the way the world's evolving, Jerry, is now we're using healthcare systems and their electronic health records and much more organized and consistent collection of data to answer important questions about care. And you just presented, I think, some fascinating information about trends in use of drugs and the increase in radial use and bleeding. Talk to us a little bit about it.
Well, what we wanted to do, Mike, was try to figure out how to provide better value. Value being higher quality at lower cost. And one of the ways we were going to address that in providing better value was targeting more appropriate use of our resources. And we observed that we had significant variability in the way coronary intervention was being performed.
Sure.
Some programs were using bivalirudin in every single case. Other programs weren't using it at all, and we felt that
there are some cath labs where there are 92 guys, and some are doing things entirely different than other guys.
Correct.
Right?
and so we felt that there was an opportunity here to get the programs who weren't using it to use it more, and for those that perhaps weren't using it in the most thoughtful manner to use it less.
Yes.
Right. And so we developed, we adopted really the bleeding risk calculator that Sunil Rao has successfully used as part of the procedure timeout. And we did a bleeding risk assessment, and for patients who were felt to be at low risk for bleeding, we recommended really heparin. For patients who were at intermediate risk, we left it up to the operator. And for patients who were felt to be at high risk, we recommended bivalirudin or transradial access. And those simple recommendations really resulted in a significant decline in bivalirudin use.
Among the low-risk patients.
Along the low-risk patients, but eventually amongst all the patients, because what we found was that this was a very potent motivating factor for the adoption of transradial access, which, as you know, many physicians have resisted.
Yes, particularly the older generation.
And we found that over 2 years, our transradial access use doubled to now about 53%. So the combination of more prudent bivalirudin use, the combination of more appropriate transradial use had significant advantages in terms of value. It reduced our bleeding rate in half. It reduced our pharmacy costs by 40%, and collectively everyone
reduced your
won.
length of stay.
Yes, collectively everyone won. The patients got better care. The hospital preserved better resources. It really was a great win.
All from a risk calculator during a timeout.
All from the risk calculator during the timeout. And part of that, though, was you can't just use it and forget about it. So every month, we would provide each facility with a summary of what percentage of patients with the risk calculator was being used. Were they complying with the recommendation or not? And we showed them their activity as opposed to the other 20 sites. And
a little bit like what we used to do with NERMI back in the old days. You know,
exactly.
Benchmarking.
Exactly. And so providing timely feedback to all of the sites and operators was really very useful in driving us towards a better destination.
Well, congratulations on getting everyone to do something consistently. I think it's hard within one hospital. It can be even harder across all these hospitals, but congratulations.
Well, thank you very much. It was really a very gratifying experience for us, and I think for the patients and physicians as well.
Trey, thanks for joining us, and thanks to all of you for joining us here from SCAI 2016.